So I wanted to talk about knee pain today for this video. And since it's football season, I want to talk about specifically football geared knee pain. So Sam, if I said knee pain and a football player, who comes to mind?
Todd Gurley.
Yes, Todd Gurley. Why does he come to mind for you?
Because he had like the most productive 2 seasons he's ever had.
5 seasons.
For a running back, he was like the #1 fantasy draft pick forever, and then all of a sudden it was like a summer hit, and then he wasn't even being drafted in like the top 4 rounds. And 2 years after that, he was retired.
And you know my treatment philosophy. If I said Todd Gurley all of a sudden had that change, that quick change that you're talking about, and he had bilateral knee pain, what's wrong with him?
If it's not just in one leg, then it has to be coming from your spine.
Has to be coming from your spine, right? And I can guarantee nobody looked at Todd Gurley's spine. So like, I actually want to tell Todd Gurley, I want to say, like, if nobody looked at your spine, nobody evaluated and properly treated your spine for your bilateral knee arthritis, that needs to be done. I want to bring you back. I want to bring Todd Gurley back to fantasy football life. I will fly out, I will evaluate you, I will see if there's something wrong with your spine that is causing that problem in your knees, and see if we can bring you back to fantasy football relevance. Now, so we want to talk about like why that's a thing, right? So the nerves in the back, specifically L2, L3, L4, go to the legs, go to the thighs, go to the knees and the innervate, everything in that, your joint, your muscles, tendons, ligaments, all that stuff, right? Now, problems in those areas of your spine can look exactly like knee pain, and it can present exactly like knee arthritis. So if in the current medical paradigm, if you go and you say, I have knee pain, the doctor does what? Looks at your knee through this scope. And a few of the diagnoses that you're going to get, I bet you he got chondromalacia. I bet you that's the diagnosis that kept coming back to him, but it's plica syndrome, fat pad syndrome, patellofemoral tracking, chondromalacia. Those are the diagnoses that'll commonly get slapped on you. And the treatment for that is basically injections. So steroid injections, cortisone injections, with some pain medication, the rooster comb injection, so the hyaluronic acid to help rebuild the cartilage or act as a little bit of a buffer. And then after that, there's really not a lot. You know, they'll stretch and strengthen the leg, but it doesn't really work. And the reason it doesn't work is because it's not the area, it's not the knee that's the problem, it's the spine, it's the nerve. The signal's not getting there. And if that happens, so we've talked about in this video, TikTok, whatever, about like the symptoms that mean spine more than they mean local joint. And one of those is if it's bilateral, right? And that's Todd Gurley. Another one is if you aren't getting better with the common treatment that you're receiving. That's Todd Gurley. Another symptom too, like if you have the spine problem, you're gonna have like heaviness of your legs. It's gonna be heavier when you're trying to move around. You're trying to go up and down stairs, you're trying to run, and it just feels like you're running in mud. And that's what Todd Gurley looked like towards the last like 2-3 years of his career. And it was sad to see. And I can guarantee that if we looked at his spine and we did a simple treatment that we're going to show here later on, the treatment that we would do or that we would think about doing with Todd Gurley, I bet you we could have prolonged his career.
Why has nobody thought of that, or it was even brought up to him? Why is there no type of information out there to even screen this?
So it's a good question. The information's out there. So I wrote a book. It's 211 pages. I have 143 citations in this 211 page book because the medical information is out there. Just you learn it in school. You had DOs, MDs, chiropractors, PTs. We all learn this in school, but nobody puts it into practice, or at least in this way. Why is nobody doing this? You think that these athletes get the best care, right? And like that's what you would think. They get the best PTs, they get the best chiropractors, they get the best osteos, they get the best DOs, they get the best surgeons and stuff. But still, regardless that it's the best, quote unquote, out there, none of these disciplines have this spine-centric approach that we have. That we first look at your symptoms, we map them out, and then we look to your spine to see if there's a cause, an actual cause, not just the symptoms, but the cause for your problem. And that's what we would do for Todd Gurley. That's what we would do for a lot of these athletes. And I bet you would be able to treat these patients, these athletes, much better than the current PTs, chiros, athletic trainers can right now.
Well, what happens for those players that they possibly get a hamstring injury or a calf injury or something like that, and then they're working with the strength and conditioning coach, or they're doing like myofascial work, and like nothing's getting better and it's taking forever, do those injuries typically last that long? Or do you also think that muscle innervation spinal treatment could have an impact on that?
No, it absolutely does. And soft tissue injuries is another one that I wanted to talk about. So you jumped the gun, but it's a good question. The soft tissue actually heals pretty quick. It depends. If it's a mild strain, somewhere around 2 to 3 weeks. If it's a moderate strain, 3 to 4 weeks. If it's a significant strain, if it's a tear, if it's a full rupture, it might need to be surgically repaired. But that's rare, right? So you're talking about that. Just recently, Joe Burrow went down with a non-contact calf injury, and then Cooper Kupp
today,
just with a hamstring injury. And so why could that be your back? The back innervates those areas, okay? So it's specifically for both of those that we're talking about, your hamstring as well as your calf. It's your L4, L5, S1, S2. So it's basically your sciatic nerve that goes to that. An irritation of that sciatic nerve looks and feels exactly like a calf strain, looks and feels exactly like a hamstring strain, and nobody out there knows this. Nobody out there, if you go to your doctor and you say, I strained my calf, they're gonna look at your calf. They're gonna evaluate your calf. It feels like it's your calf. They're gonna think it's your calf. They're gonna treat your calf. They don't then look at your back. They don't look at your spine to see if there was a different reason for your symptoms. So not only can it look and feel exactly like a soft tissue injury in your hamstring and your calf, but it could cause it. Okay, so you think about your spine, your spinal cord turns into spinal nerves, and then it goes out all through your body like little root system here, right? Mm-hmm. So it innervates everything in your body. If that signal isn't getting to your gastroc, isn't getting to your hamstring as quickly as it should, as strongly as it should, you're gonna have weakness. It's gonna be easily fatigable. It's gonna feel thicker. It's gonna feel like it's not as readily available for you there. You're gonna have to think about it more in order to use that muscle. It won't recover as well. It'll be sorer than it should be. And again, you won't know that it's coming from your back. There are a few signs and symptoms. So for Todd Gurley for his knees, right? Most of these patients are a flexion responder for that L2, L3, L4. So we want to flex their lumbar spine in order to fix these symptoms, right? Because of that, these patients often can't sleep on their stomach because they get locked up in their back. So again, I'm wondering, Todd Gurley, if you lay on your stomach too long after he's sat for a while, and there's something called moviegoer sign, and it's a sign of chondromalacia, but that's wrong. We're just wrong. It's wrong because we don't also look for a spinal origin of the cause. And we're going to show a little bit here about how we would treat both conditions, talking about Todd Gurley's knees or Joe Burrow's calf or Cooper Kupp's hamstring. The soft tissue injury that I wanted to talk about actually was Keenan Allen. So do you remember the trade we made last year? I gave you Jamar Chase. You gave me Josh Allen, I believe.
Yes.
And I got Keenan Allen. I came out so far ahead on that trade, but it did hinge on Keenan Allen being healthy. We did that trade.
Yeah, that's why I leveraged him, because I didn't think he'd be healthy.
We did that trade when he was on the DL, right? He stayed on the DL for way too long. You said, is there a normal healing time? Yeah, there's a normal healing time, and he was well past that. They were on a bye. Over the bye, he got worse. You don't get worse. Your muscles, tendons, they heal if you rest them. You do not get worse. You do get worse if you have a spine problem, and during that time you've put your spine in a bad position, laying on your stomach, sitting for too long in like an extended position. Driving is actually a nerve tension position. So like just sitting too much like that could actually tension the sciatic nerve. And nobody was looking at this. And I want to tell all these players, I want to tell Keenan Allen, I want to tell Joe Burrow, I want to tell Cooper Kupp, and I want to tell Todd Gurley, I want to ask you, did anybody look at your spine? Did anybody properly assess, evaluate, and treat your spine? Not just ask you to bend over and stand up like the normal bullshit scoliosis treatment that everybody does when you're in 5th grade. Did they actually press on your spine? Did they press on the center of your spine, on the sides of your spine, so on the facets, on the transverse process? And then did it see if that changed your symptoms? My guess is no. That's a better way to treat, a more complete way to treat, and you're actually treating the cause. So I can get these players better quicker and more complete than the current athletic trainers, PTs, chiropractors that they have.
When you were working on these players, would they be able to tell when you hit a certain segment of their spine that was the area that is upset? So
what we do is we set your distal relevant symptoms. So if you come in for your knee, we want to see right then and there where does your knee hurt? Does it hurt when you squat? Does it hurt when you go up and down steps? What range does it hurt at? Where does it hurt in your knee? How much does it hurt during any of these movements? Split squats, lunges, going up and down steps. Then we look to your spine and we start pressing on these segments. Typically, again, for the knee, it's L2, L3, L4. If you get to that area, you'd be surprised on how little force is needed to elicit a pretty big symptom of pain, or how stiff some of these segments are. They're not moving, and that's causing some increased pressure on these nerves. Those nerves are shutting down, and then that's causing the knee pain. I use an analogy in the book. When you have a leak in your ceiling, when you see a wet spot in your ceiling, there's not a problem with your ceiling, there's a problem with your roof. Our bodies are kind of the same way. You feel it, you see it in your knee, but it's actually occurring further up. It's closer to your spine, and that happens so much more than anybody out there realizes.
Nice. And would you be able to tell a difference once you worked on that segment of the spine and then they got up? Do you retest them and then you see that their strength or mobility improves?
Yeah, we retest them after you work on the area of their spine, and then you see if those symptoms that you had mapped out change. And that's, again, it seems like a pretty linear, logical way of treatment. You want to see changes right then and there. And if you do see those changes, if you do find those correlating areas of your spine that are tender to where they go to your symptoms, you see some changes, you're pretty sure you're on the right track, and then you just keep going. And most of the time, again, if you're doing something and it's the right area and the right movement, it works. It works well, and it works relatively quickly. And for these joint issues, they respond much quicker than some of the other like internal issues that we treat.
Do you find that once you make those changes, that those changes go back to how it was before over the course of a few days? How often would you
there
need
needs
to
to be
treat them?
there needs to be some maintenance. So then we find an exercise that the patient can do to kind of mimic the same treatment that we're doing, so that way they can maintain it. We teach them how to avoid certain positions. So again, for the knees, it's typically this like ass out position. Their lower back is extended, right? So for that, you wouldn't want to sleep on your stomach. You wouldn't want to sit on like a chair with actually really good lumbar support, because it sticks you up in that extended position. You want to try to slouch. You want to sleep on your back, maybe with your knees up a little bit, or on your side with your knees really cocked up, like kind of in the fetal position. You want to sit in more of a bucket chair, because that causes you to have that like posterior pelvic tilt. You want to stretch out the muscles that have been too shortened, which would be like right in the lower back, and then you want to strengthen the muscles that have been too lengthened, that become weak, and that's your abdominals for these patients. You teach them how to do this. So your body needs basically two things. Your body needs mobility and stability. Another way to say that is range of motion and strength. You want to get the range of motion into a range that they haven't been able to go to because they've been stiff, and also because they've been weak. So you show them how to get range of motion, mobility for this, and then you show them how to get stability, strength for this. It's really simple. Medicine should be much simpler than we make it. We make it way too difficult. We get micro focused in just one area, and we use too many injections and medications. We try to get cellular and your microbiology and stuff. It is much simpler than we're making it out to be.
Then let's say you were to do this and someone would say, hey, I've been on medication for this long, or I've been doing this for this long and nothing has been working. Are there any downsides to giving this a go? Like, is it just the information's not out there, so that's why people don't know that this even exists? Or is there a potential risk involved with doing any of this?
There's much less risk with this than there is with taking medication. And again, the medication, all these medications that I listed before, again, like the cortisone injections, the pain medications, even some of like the Symvisc stuff, all it does is mask your symptoms. It just turns your body, it numbs your body to your symptoms. And that's dangerous, especially for these athletes, right? Like they need to know what their body's feeling, how their body's reacting. There's pain there for a reason. You're gonna get a cortisone injection. The pain is still there, the problem's still there. You don't feel it, but now you're gonna go out and play and your quad's not firing as quickly. And again, at these elite levels, they need that. 2% change for me and you isn't going to do anything. We'll still be able to go up and down stairs and sit at our computer and text back and forth, but these guys, they won't be able to cut as quickly. Their quad won't turn on, so their quad won't protect their knees, so that'll lead to ACL tears. These little trickle down the road, kick the can down the road medicine that we've turned into, it's dangerous, and especially for the athletes.